Hi, we're going to get started in a moment. Hello, my name is Amir Garakani. I'm a psychiatrist and the Director of Education here at Silver Hill Hospital in New Canaan, Connecticut. And I'm very happy to say that we're going to be having grand rounds today. And the topic will be alcohol use disorders and pharmacotherapeutic approaches. Before I introduce our speaker, Dr. Levounis, let me just get some housekeeping out of the way. We can take questions and we'd love to hear from you. At the end of the lecture, I will pose some questions to Dr. Levounis that are submitted by you. You look at the bottom of your screen, the Q&A bubble, just submit the questions there. I'll review them and then I will present them to Dr. Levounis. We have about 15, 20 minutes at the end for questions. At the end of the talk, you will get an opportunity to submit for CME or CEC credits. So just fill out the survey. If it doesn't pop up in your screen, you'll get an email copy as well. And you should get a copy of your certificate shortly after the completion. Lastly, no Silver Hill planners of this activity have any relevant financial disclosures at this time. So let me get to introducing Dr. Levounis. I could spend a lot of time with this. There's a lot to say. Dr. Levounis is very accomplished. So I'll just try to give you the brief overview. But Dr. Levounis is the professor and chair of the Department of Psychiatry and the associate dean of professional development at Rutgers, New Jersey Medical School, and the chief of service at University Hospital, Newark, New Jersey. He came to Rutgers from Columbia University, where he was the director of the Addiction Institute from 2002 to 2013. Dr. Levounis is a Phi Beta Kappa graduate of Stanford, where he studied chemistry and biophysics before going on to do his medical education at Stanford and the Medical College of Pennsylvania. During medical school, he studied research on the effects of social class on patient-physician relationships at Oxford, and also received a master's from sociology at Stanford. He did his residency training at New York State Psychiatric Institute, Columbia, where he was an NIMH outstanding resident, and did his fellowship in addiction psychiatry at NYU. He has written many, many books and book chapters on many topics, including addiction psychiatry, and has lectured extensively on these topics abroad and in the US, and has appeared on CBS, ABC, NBC. He's a face that many of you have probably seen on news shows, also in the New York Times and Washington Post. He is, without a doubt, an authority on all kinds of topics related to addiction and psychiatry in general. He served on the board of ASAM, the American Society of Addiction Medicine, and the American Board of Addiction Medicine, and chaired the National Committee for the Addiction Treatment at the APA. He's also a Betty Ford Scholar and a recipient of the Association of Gay and Lesbian Psychiatrists Distinguished Service Award and ASAM Educator of the Year Award, and is a distinguished fellow of the APA and ASAM, and was recently elected as an honorary member of the World Psychiatric Association, which is quite an honor. He's written many books. I could go into all of them, but books like self-help books like Sober Siblings. He's written books on, including an authoritative textbook on substance dependence and co-occurring psychiatric disorders, and motivational interviewing, behavioral addictions, and has a book that he's working on technological addictions. His books have been translated into many languages. And this is a copy of a book we use for addiction medicine. I remember reading this book and seeing several chapters, written by Dr. Levounis. During my addiction medicine studies, I've heard him give some wonderful talks, and in the midst of many, many hours of repeated lectures, his stood out as some of the most funny and engaging and interesting. And it's no small feat, because they can get really dry after 6 hours of sitting listening to lectures. You kind of get a little burned out, but his were always really well done and really dynamic. And I still have the slides highlighted, and still remember things from them, because he is that good a teacher. And when I thought, like, we need to bring someone back to talk about alcoholism because it's such an important topic, I thought Dr. Levounis would be the perfect person, and I'm so happy and honored he's here. and I'm looking forward to having him talk. Dr. Levounis.
Okay, thank you so much for this truly wonderful introduction. And well, I did something right because you passed your boards. So I'm very proud of that. Thank you for inviting me to give this lecture today on alcohol use disorder and pharmacotherapeutic approaches. I have no relevant financial disclosures. And the way I would like us to do this is in 6 parts. We're going to start with the lay of the land, specifically of the COVID-19 land. Where do we stand in 2021? Then go into screening and brief intervention for alcohol use disorders. A few words about intoxication and withdrawal. We're not going to spend too much time on these matters, but we should certainly touch upon them. And then we're going to delve into number 4, which is the main part of this presentation, the pharmacological treatments of alcohol use disorder. A few words about psychosocial intervention. And since we are working on the GABA receptor and the sedative effects of alcohol, we might as well mention benzodiazepines before we conclude. So that's what I plan to cover. Hopefully, it's not going to be much more than an hour, and then we can open it up for discussion and questions. Okay. All right. So let's start from the lay of the COVID-19 land, and before doing so, let's talk about anxiety. The anxiety lifetime prevalence is about 17%, and that compares to the mood disorders, with depression being a little over 20%, the alcohol use disorders being maybe 28%, and then drug use disorders about 10%. So that's the lifetime prevalence of anxiety in our world. Very difficult actually to pinpoint down the exact numbers, but that's the best we can come up with. Why do I bring that up? Because a lot of people, especially under stressful circumstances, would self-medicate anxiety with alcohol. And that, of course, is also true during the COVID-19 pandemic, where anxiety levels went up and alcohol kind of followed. This is the most recent data. These are the most recent data on psychiatric disorders. It was published in May of 2021, so just a few days ago, really. And what we have in front of us is in blue, the general population, and in green, the specifics about the health professionals. So as you see here, anxiety has moved up to about 21%. And interestingly, just as a side here, while PTSS stands for post-traumatic stress symptoms, not exactly post-traumatic stress disorder, but a wider form of post-traumatic stress symptomatology. And you see that health professionals have considerably higher rates of PTSS than the general public. But then when you go to the very right of this diagram, you see that the overall mental health of the general public is considerably worse than the overall mental health of health professionals. And that may have to do with the increased resources that health professionals, all of us have, financial resources and intellectual resources perhaps, and social resources and so on. So although more stress, better overall mental health. But going back to anxiety, anxiety has gone up, and consequently the alcohol use has gone up. But there's a caveat to that, and I would like us to spend a couple of minutes on that. Here is the Aladio study from Frontiers of Psychiatry, again in 2021, that studied alcohol during the pandemic. And it does seem that the overall alcohol intake of social consumer has been observed to decrease. So we're having an increased anxiety due to the pandemic, and yet we see that among social consumers, the alcohol has been decreasing. Why would that be? That may be? Well, for one thing, the bars are closed. So when you think about people going out and socializing and drinking, the opportunities for that among social consumers has decreased. Contrast that with the second major point about alcohol from the same study, that the consumption from chronic excessive drinkers showed an alarming increase, which is something that is very consistent with what we see following disasters. It was first identified by Carol North, who did the seminal work on the Oklahoma City bombing, and what happened, what were the mental health consequences of the Oklahoma City bombing several decades ago, actually, now. And what she found was that although PTSD, of course, went up, and several other mental disorders among the people who were highly exposed to the traumatic event, she also found that there were no new cases of alcohol and drug use disorders. Significant deterioration of people who were already drinking, significant relapse for people who were drinkers and then had stopped drinking, but not so much new onset alcohol use disorders, which is very consistent with these findings that we have from the COVID-19 data. Let me make it as simple as I can. Social drinkers, people who just drink here and there and don't necessarily have a problem with it, probably reduced their alcohol intake. Problematic drinkers and people who suffer from the entire disorder of alcohol use disorder, they probably fared much worse, an alarming increase in their alcohol intake, worsening of the disorder and relapse from people who had been abstinent. Okay. Couple of more things in the spirit of lay of the land. These are alcoholic drinks from the 20th century, the good old colorful cocktails. We still have them today, but they certainly bring back 70s ideas. But we do have some new concoctions in the 21st century that we did not have back in the 20th century. What you have in front of you are alcoholic drinks masquerading as soft drinks that have become quite popular among youth. These products, one of the most famous ones is Four Loko, are very troubling for two main reasons. First of all, just look up here, 12% alcohol. Contrast with beer. Most beers have 4, 5, maybe 6% alcohol, and these cans have 12% alcohol in them. So they're much, much stronger. Second problem with them is that they also contain 4 shots of espresso in each one of these cans. Now, alcohol has a built-in protective mechanism against alcohol poisoning, coma, and death. And that is that you drink. At some point, you pass out, and physically, you cannot continue drinking. Enter 4 shots of espresso that prolong your physical ability to drink alcohol to the point of alarming respiratory depression, coma, and death. These products have been outlawed, but then they came back, and then they tried to be outlawed again, and they came back again, and it's a cat and mouse game, which at least I think is won by the people who make the products rather than the people who try to stop them. All right, moving on to screening and brief intervention. The good old CAGE questionnaire for screening for alcohol use disorders. Anybody in this audience who has taken exams or boards or anything like this had to memorize the CAGE questionnaire. Have you ever tried to cut down your alcohol intake? Have you been annoyed by people asking you about your drinking? Have you ever felt guilty about your drinking habits? And of course, the most specific one, have you ever had an eye opener, meaning have to have an alcoholic drink first thing in the morning so that you can stave off the alcohol withdrawal that brewed over the night? Very similar to the first cigarette for people who are cigarette smokers. They went into a mini withdrawal during the night, and then they have an increased craving for smoking a cigarette in order to satisfy the mini withdrawal that they suffer during the night. Similar idea. A CAGE questionnaire, it's excellent, it's good, it has good sensitivity, good specificity. The problem with it is that it's not particularly user-friendly as a screening instrument. Meaning, if you have somebody and you ask the question, have you ever felt guilty about your drink? And they say yes. You cannot just go to the eye opener. You want to explore that. You want to have a conversation about that. So it's not quite as quick as one would have hoped for as a screening instrument. So the National Institute on Alcohol Abuse and Alcoholism worked very, very hard for many years to come up with a single question, that would screen for alcohol use disorders. And before revealing that single question, let's review what constitutes a standard drink. The easiest way to remember that is probably a 12-ounce can of beer. That's not the bigger ones, not the smaller ones. The classic can of beer is a standard drink. All right, here's the question. Have you ever had 5 or more drinks in a sitting, if you're a man? Or have you ever had 4 or more standard drinks in a sitting, if you're a woman? There are also some weekly cutoff points, but they're not as helpful as the one about how many drinks have you had when you sit down to drink. Now let's think about this for a minute here. If every time you sit down to drink, you have to have a 6-pack or more, one of 2 things is happening most likely. Number one, maybe you have an impulse control issue. Maybe you start feeling the effects of alcohol with drink number 1 and 2 and 3, but you have an impulse discontrol problem and you have to go to 6 and 7 and 8, which of course it's a red flag because you have an impulse control problem. Second explanation is that perhaps you don't feel very much with drink number 1 and 2 and 3, and you have to go to 5 and 6 and 7 and 8 in order to feel something, in which case it means that you have high tolerance to alcohol. Having high tolerance to alcohol is a major predictive factor for alcohol use disorder. People who have high tolerance to alcohol, either they have been drinking for a long time and they developed that high tolerance to alcohol, which of course is problematic, or genetically they have high tolerance to alcohol, which is also a big red flag for alcoholism. We now know that the genes that code for alcohol use disorder run parallel, or they're very closely associated to the genes that code for high tolerance to alcohol. We're not sure about the cause and effect relationship between the two, if any, but the association is very strong. So clinically, what am I talking about? The kid who comes to me and says, Doc, I can drink everybody under the table at the fraternity where I'm at, therefore I will never become an alcoholic like my father. He has it exactly wrong. The very fact that he can drink everybody under the table at the fraternity where he's at puts him at the greatest risk of becoming an alcoholic like his father on a genetic basis. So that's why this question is so wonderful, is because with a single question, you have captured three at-risk populations: the people with a poor impulse control, the people who have been drinking a lot and they have developed high tolerance to alcohol, and the people who genetically come in with a high tolerance for alcohol. All right. Something to remember about the how much is too much. Every time we have a standard drink, we add 20 points or 0.02 if you want to go with milligrams per liter on one's blood alcohol level. So if you have 3 drinks, you can, one after another, you can expect your BAL to be about 60 or about 0.06 on the legal side. When you come down by 20 points every hour, or about every hour. If you remember again from taking boards, this is called zero order kinetics. So the 3 drinks that you had that brought up your BAL to 60 will take about 3 hours or maybe 4 hours to get out of your system. Now, this rule of 20s that was very helpful to people who would go to parties and drink and think about driving afterwards has been superseded, of course, today by the internet, where you can go to any site, you can Google it right away, and there are calculators who will tell you exactly or much more accurately what your BAL may be. You put in your gender, you put in how many drinks you've had, at what time, and it will tell you your BAL is most likely such and such. All right. Now, this is an important piece here. This is the one I want to teach you how to perform a brief intervention for alcoholism. Now, SBIRT, as you may have heard, screening, brief intervention, and referral to treatment, was thought to be the answer for pretty much all substance use disorders. That may not really be the case because cocaine and crystal methamphetamine and heroin may need much more than a brief intervention. But for alcohol, brief intervention has been shown over and over and over again to be safe and effective and very helpful. So for alcohol use disorders, that's what we do in terms of brief intervention. Here it is. First of all, you have to be empathic and curious. I don't really need to teach you that. You know that this is a part of how we approach all our patients with substance use disorders. This is a sophisticated audience here, but let's just remind ourselves being empathic and curious in the spirit of motivational interviewing and pretty much all kinds of psychotherapy that we do these days with patients who suffer from alcohol use disorders. And then the brief intervention has 3 major parts. First part, you state your medical findings in a very non-judgmental, matter-of-fact kind of way. You tell the patient, that's what I see here. I see your liver function tests are elevated. I see that you had 2 DWIs over the past 5 years. I see that the wife took the kids and left you. Whatever it is that you have gathered from your history taking, your laboratory examinations, your physical exam. Next step, you educate the patient about alcohol use disorders. That's what we now know. That's what science says. It is a medical illness, very much like hypertension and depression and everything else, a chronic relapsing illness, and that's what we know. And the next step is to allow the patient to bring these two parts together, perhaps have an aha moment, and then advise the patient for next steps. That's what we can offer. That's what we have in terms of psychotherapeutic approaches, mutual help groups, medications, and advise the patient of where do we go next. Of course, you follow up and you refer if absolutely necessary. I'm an addiction psychiatrist. I would love to see your patients, but chances are they're not going to come to me. They were going to stay with you, with the people whom they know. So referral only when it gets to the point where you absolutely need some extra help from somebody on the outside. All right. Moving on to intoxication and withdrawal. I'm going to go a little fast here because, as I mentioned before, these are very medical issues that a few of you will be directly involved in the treatment of intoxication and withdrawal, and I'll be happy to answer any questions. Here is the different levels of intoxication. For people who have very high tolerance to alcohol, they don't need to get, they may very well be at 600, 400, 500 milligrams per deciliter and still converse with you. Why? Because they developed such high tolerance to alcohol. In terms of treatment, it's supportive. We make sure we give them some thiamine to replenish the thiamine that they have before adding any glucose. But any other intervention that we've tried, and we've tried a bunch of things, have not really helped with alcohol. The way to remember that is that alcohol is a very small molecule, that it goes into all kinds of tissues really quickly. So trying to induce emesis or activated charcoal is a losing battle. So treatment is supportive. In terms of withdrawal, this is a serious problem. It's not like opioid withdrawal, which is incredibly uncomfortable but not medically dangerous. Alcohol withdrawal can be medically dangerous, and it has a specific progression from high blood pressure and high pulse to perhaps having seizures to all the way to DTs, the delirium tremens. So we do treat with benzodiazepines, and the way we do that is symptom-triggered benzodiazepine use. We check where the patient's symptoms are, and then we give them the appropriate amount of benzodiazepine. In general, we use long-acting benzodiazepines like chlordiazepoxide, unless the patient has significant liver disease or is elderly, in which case we use lorazepam, which does not accumulate and does not get the patient overly sedated. As I mentioned before, we do the symptom-triggered benzodiazepine treatment, and that is called SIWA. I'm pretty sure most of you know already about it. And the major advantage of SIWA is that it protects the patient from unnecessary benzodiazepines. Because if you end up on the mild side of withdrawal, then hydration and rest will be all you need. And even moderate withdrawal will need small amounts of benzodiazepines. Severe withdrawal, on the other hand, is something that may lead to an ICU admission. All right. And here we go to the pharmacological treatments, the long-term treatments for alcohol use disorder. And that's where I want to spend the next half hour or so discussing. So what do we have? Before getting into the specific medications, let's just review the neurotransmitter systems affected by alcohol. Alcohol is often said to be a dirty drug. Again, it's a very small molecule, so it affects all kinds of different neurotransmitter systems in the brain, including the dopamine and the opioid system, the serotonin, the cannabinoid system. But the two workhorses of alcohol, the two major effects of alcohol, have to do with the GABA system, gamma aminobutyric acid, and glutamate. GABA results in central nervous system inhibition. It's the major neurotransmitter that results in central nervous system inhibition. And glutamate, an excitatory amino acid, is primarily responsible for central nervous system excitation. That's what they do. Alcohol promotes GABA activity and inhibits glutamate activity. Say that again. Alcohol is a promoter of the GABA system and inhibitor of the glutamate system. So, synergistically, by promoting GABA, by promoting an inhibitory system, and by inhibiting an excitatory system, you end up with overall central nervous system depression. Okay? Some time ago, we used to think that alcohol has a biphasic effect, that at lower doses it excites the brain, and at higher doses it suppresses the brain. But it's not true. We don't believe that anymore. Alcohol has a suppressing activity from the get-go, even from the lower doses. But what happens is that at lower doses, alcohol has some specificity for the frontal lobes. So it suppresses the frontal lobes, and that's why people say the things that they're not supposed to say and grab things and are belligerent, and they present themselves as if they're excited. Meanwhile, it is the effect of the suppression of the more civilized part of our brain because of the regional specificity of lower doses of alcohol. At higher doses, alcohol suppresses the basal ganglia and the motor center of the brain, and therefore people have unsteady gait and slurred speech. And at even higher doses, alcohol suppresses the brain stem, the respiratory center of the brain, leading into coma and death. All right, so with these things in mind, let's move on to our three medications, the three FDA-approved medications for alcohol use disorder. Before getting even to that, I do have a general comment to make about pharmacotherapy of alcohol use disorder. In 2021, the overall treatment of addiction, all of addiction, including the behavioral addictions and opioids and stimulants and cannabis and everything, continues to be primarily psychosocial. Individual psychotherapy, group psychotherapy, 12-step programs, partial hospitalizations, these are the things that actually get patients better. There are only two addictions for which we have found really strong medications, and for which the medication is the first-line treatment for the disorder. And these, of course, are opioid use disorders and tobacco use disorders. Just those two, opioids and tobacco. For those two, the patient comes in suffering from opioid use disorder or tobacco use disorder, you are pretty much required to offer the possibility of medication. Why? Because the medications are so strong that they can carry a lot of the burden of illness on their shoulder. Not the same with alcohol. We do have 3 FDA-approved medications, and I use them, and I want you to use them as well, and I want you to be familiar with them, but they are not the main treatment. The director of the National Institute on Alcohol Abuse and Alcoholism, George Koob, often calls them hamburger helpers. Hamburger helpers. Yes, they're good, they should be used, but don't expect them to really carry the day in the absence of significant psychosocial interventions. All right. Let's start with naltrexone. Most of naltrexone these days is given as an injectable extended release form in the gluteal muscle. This is the molecule. I put it up there so that people who are into chemistry and they like molecules, I'm sure it will remind them right away of morphine. It's very similar to morphine, but it's an antagonist to the mu-opioid receptor, and that is what it does so well. It blocks the mu-opioid system. All right. How does it do that? We recognize two types of cravings for alcohol. There is a reward craving and an abstinence craving. Both of them terrible names, but that's what we're stuck with. Reward craving is the craving that one has for alcohol, where they're happy-go-lucky, they just don't feel bad, don't feel good, they're just fine. They start drinking and they start feeling this positive feedback mechanism. They activate their dopamine system, they activate their opioid system, they sense this galloping need for more and more and more and more alcohol, and before you know it, they're plastered. That is a reward craving. Naltrexone primarily affects the reward craving system of alcohol, and that is its main mechanism of action. Let's look at how that works. Okay, and that's where I need your full attention. Let's say you drink for a long time and you stop drinking. All right. When you stop drinking, you don't start on any medication, just stop drinking abruptly. You may have your acute withdrawal, but then let's say after you're all right with all that, 3 weeks later, you have a craving for alcohol. You have a couple of beers and you skyrocket your opioid and dopamine systems that now have regained, have lost their tolerance because of your 3-week abstinence. So you drink, you stop drinking. 3 weeks later, you have a couple of beers, your opioid and dopamine system go haywire in your brain, you experience this reward cravings, and before you know it, you have fully relapsed. Now, let's take a second scenario. You drink, you stop drinking, and the day after you stop drinking, you start yourself on naltrexone, either orally every day, 50 milligrams every day, or by injection in the gluteal muscle, as I mentioned before, 380 milligrams once a month. All right. 3 weeks later, something happens and you have a couple of beers. Yes, you're going to feel high, but you're not going to feel nearly as high as you would without the naltrexone protection. Why? Naltrexone has blocked the opioid system and has made those 2 beers not quite as rewarding. It has reduced the reward cravings for alcohol, meaning that the patient has a little more of a chance of saying, whoa, what am I doing here? Do I want to go back to this life of drinking and all that stuff that came along with it? Or perhaps I'm going to go to a meeting or call my therapist or go and see my sponsor, do something to reestablish my sobriety, jump back on the wagon, and therefore not relapse. So in a very clever fashion, what naltrexone does is it concedes some drinks here and there, and essentially targets the second set of drinks after a period of abstinence. You say, okay, if you're going to have a drink here and there, what I'm going to do for you is I'm going to make those drinks less rewarding, and therefore reducing the chance of you going back to heavy drinking. It prevents the sleep from graduating and becoming a full-blown relapse. All right, as I mentioned before, the oral form, 50 milligrams a day. Last I checked, and I did check right before this lecture, about $100 a month. You do get some liver toxicity, so you do have to follow liver function tests. And of course, it's an opioid antagonist, so it does not fare well with patients who need opioid-containing agents for chronic pain or for any other condition that requires opioids, including treatment with buprenorphine. All right, Second way of delivering naltrexone, the injectable, 380 milligrams a month. There are these microspheres that disintegrate in large muscles, and they provide the naltrexone in the bloodstream. It's very expensive, although there are some coupons and things that people can get and reduce the price. There are some injection site reactions. It is water soluble, it's not lipid soluble, but it's a large volume, it's over 3 cc's, and people have described discomfort to it. The other thing to remember is that it has to be given in the gluteal muscle, which makes it logistically difficult. You are a psychiatrist in private practice, you have a nice office with a desk and a couch. How is it exactly going to happen to give, let's say you're a man and you have a woman patient, and you're going to have a nice discussion about the treatment, and then at the end of the session, how are you going to give that injection to that patient? You don't have a treatment room, you don't have a nurse, so there are logistics that have to be thought out as well. All right, going on to the second medication, the second major medication that we have, and that is acamprosate. Here it is given very often in a 3-month supply with little bubbles that pop out, and this is the molecule. Nothing too much to say about it, except that it's a very small molecule, and I just put it here because I love molecules myself, and I just thought it would be kind of nice to know what it looks like. All right. As advertised, there is a second type of craving for alcohol, and that's called abstinence craving. What is that? That is when you have stopped using alcohol, and after the acute withdrawal, you still feel miserable. Sometimes it's called the protracted withdrawal syndrome, sometimes called the post-acute withdrawal syndrome. And that is when you feel miserable and you really need the drink in order to normalize, in order to feel okay. Let's take a timeline once again. All right, so you drink for a long time. During that long time, you have been activating your GABA system and you have been depressing your glutamate system. Let's put the GABA system aside for a minute and let's focus on the glutamate system. So chronically, you have been inhibiting glutamate. What is the body going to do? It's going to try to counteract that chronic inhibition. And how does it do that? It upregulates the glutamate system. It makes more postsynaptic receptors. It makes better functioning postsynaptic receptors. It essentially revs up. And in fact, it does a fairly good job in balancing excitation and inhibition in the brain. I don't know how many of you may have watched the movie Another Round, a Danish movie, just came out, actually won the Oscar for Best Foreign Film. And it addresses exactly that kind of issue of having some kind of balance in the brain after chronic ingestion of alcohol. Wonderful movie, by the way. All right, so all this is nice and good and fine, and that's how a lot of chronic alcoholics live their lives. Then all of a sudden, let's say you stop drinking. Great, fantastic, you stop your alcohol. What you're left behind is a hugely upregulated glutamate system that is now unopposed. And that's how you see the increased heart rate and the increased blood pressure and sometimes the seizures and the delirium tremens in the acute withdrawal, due to the upregulated glutamate system that is now unopposed. But even after the acute withdrawal, what you see is still a hyperactive glutamate system that gives the person this protracted withdrawal syndrome, the post-acute withdrawal syndrome that is characterized by anxiety and insomnia and generalized malaise and restlessness and discomfort and sometimes aggressivity, that kind of feeling terrible. And of course, that is what gives rise to the abstinence, cravings, and gets the person to relapse, to have one drink in order to be able to be okay. Enter acamprosate. Acamprosate interferes with the glutamate system, cools down that protracted withdrawal syndrome, and therefore reduces the chances of the person to relapse. If naltrexone is particularly good in cutting down heavy drinking, acamprosate is particularly good in helping people stay abstinent. Both of those are very valid outcome measures in alcohol research and in alcohol clinical work. We want people to reduce their heavy drinking, and we want to promote prolonged abstinence. And both naltrexone and acamprosate do both, but naltrexone does a little better job in reducing heavy drinking, and acamprosate does a little better job in promoting abstinence. Both do both. It's which flavor is most. And that's where patient goals also come into consideration as well. What is the patient really looking forward to do here, and how can we work with the patient to meet their goals? Okay, dosing, 666 milligrams 3 times a day. I mean, what marketing genius came up with that? 666, I mean, we have Catholic patients, and who would, why 666 and not 667, let's say, and we have to, have our patients take 3 times a day 666 in their mouths. Anyway, it is what it is, and that's the dosing of it. If naltrexone did a little bit of has a problem with liver, and you need to continue watching for liver function tests, acamprosate does not have a problem with the liver, but it does have perhaps a consideration for kidney disease. Excuse me. If the patient has significant kidney problems, then you may need to reduce the dose. And if it has significant kidney problems, then you may not be able to give acamprosate altogether. So one major consideration between naltrexone and acamprosate is the goals of the treatment in terms of reducing heavy drinking versus prolonged abstinence. And the second consideration in making a choice between naltrexone and acamprosate is whether the patient has liver problems, which moves us more in the direction of acamprosate, or has kidney problems, in which case it moves us a little more in the direction of naltrexone. Okay? All right. And now the third FDA-approved medication, Disulfiram. It's the oldest medication. It is not used very much anymore. You can still find it in a generic form. I believe that the company that makes Disulfiram discontinued making it a few months ago, I think December of 2020. But it's still available in a generic form, and it has its place in our work. And I'll try to discuss this. But it's not as major as naltrexone and acamprosate. That's actually the American Psychiatric Association, in its recommendations for the pharmacotherapy of alcohol use disorders, did not include disulfiram, although it is FDA approved, just mentions the naltrexone and acamprosate. But we do need to cover it as well. Here it is. It's the oldest one. It's very, very cheap. And here is the molecule for people who may want to be interested in the chemistry of it. All right. What does it do? When we drink alcohol, that alcohol very quickly becomes acetaldehyde, and that acetaldehyde oxidizes further, becomes acetate, and then acetate oxidizes further and becomes carbon dioxide, and we actually breathe alcohol out. Acetaldehyde is a very toxic molecule. Acetate is a neutral molecule. This very moment that we speak, you have gazillion acetate molecules running all over your body, and you don't feel them because it's a very neutral, very benign molecule. Acetaldehyde, on the other hand, is very toxic. But if we drink alcohol, the majority of us will make acetaldehyde really quickly, but the acetaldehyde very quickly becomes acetate, and we never experience it. There are some Asian populations that do have a decreased activity of acetaldehyde dehydrogenase, the enzyme responsible for the metabolism of acetaldehyde into acetate. And of course, for these people, even half a glass of wine may give them a flushing reaction and make them uncomfortable. Incomplete activity of acetaldehyde dehydrogenase among some world populations. This is exactly the property that disulfiram capitalizes on. Disulfiram irreversibly and completely blocks acetaldehyde dehydrogenase. So when you are on disulfiram and you have a couple, if you don't drink alcohol, you don't even feel it. You don't really know anything about it. However, the moment you have some alcohol, that alcohol immediately becomes acetaldehyde. Acetaldehyde has nowhere to go. It accumulates and it gives you the disulfiram reaction, a very uncomfortable reaction with nausea and vomiting and flushing and discomfort, and you don't want to do it again. So it is a punitive way of treating addiction. And as you know, across the board, including the pharmacotherapy of addiction, we've moved away from highly punitive interventions in favor of motivational interventions. So disulfiram is not a particularly strong medication, it's not particularly effective, but it also reflects an outdated way of thinking about treatment. You do as I say, or else you get the disulfiram reaction, and that will teach you a lesson, and you won't want to do that ever again. We haven't found that to be particularly helpful for our patients. Depending on body habitus, 250 to 500 milligrams a day. It is relatively cheap, as I mentioned before. You do get some liver toxicity, and you have to follow liver function tests. Now, there's another story with disulfiram. And I'm going to mention it because I think it's rather interesting. Disulfiram, from a very, very different mechanism of action, blocks dopamine beta hydroxylase centrally. So disulfiram blocks the enzyme that breaks down dopamine. So you wouldn't really want to give disulfiram to a patient who suffers from schizophrenia. If anything, we want to reduce dopamine activity in the patient's brain who suffers from schizophrenia. We don't want to have more dopamine due to the inhibition of the enzyme that breaks down dopamine. That's one thing. Second thing is the fact that people who have coronary artery disease, you don't want to be increasing the dopamine levels on somebody whose coronary arteries are not particularly well functioning. And the third thing, which is a little fascinating to me, is that disulfiram is being studied for the treatment of cocaine addiction. And here's the, I mean, you would think cocaine, of course, increases dopamine activity. And you say, wow, you want to give somebody disulfiram who already are using cocaine and they have a hyperactivated dopamine system. Yes, the idea is that if you are on disulfiram and you use cocaine, you're going to get your dopamine level to such an incredibly high level that it's going to start getting annoying to you, that you're going to be buzzing with too much dopamine, and that is going to get you kind of jittery, and you are going to have a discouraging effect from the medication. Anyway, I'm just putting that aside. I think it's a fascinating mechanism of action. It is not FDA approved for cocaine addiction, and even the research has nearly not gone very far anyway. If you decide to use disulfiram, you do have to be careful with some drug-drug interactions, but in general, it's a pretty well tolerated medication. Finally, I want to cover a few more non-FDA approved medications. They should be considered as a second or third line intervention in the pharmacotherapy of alcohol use disorders. Let me just say a few things about each one of them. Gabapentin is probably the one that has been studied the most. It was started by John Mariani and colleagues at Beth Israel some years ago, and was found to be very helpful in acute withdrawal as well as in protracted withdrawal. So at some point we had this idea that wouldn't it be wonderful to have somebody with severe alcohol withdrawal, we give them high dose gabapentin up front for the treatment of acute withdrawal, and then we discharge them with lower levels of gabapentin for the treatment of the protracted withdrawal. It makes sense. However, the indication was never pursued. The pharmaceutical company that makes gabapentin never wanted to be associated. That's my explanation, maybe other reasons, with alcohol use disorder. But in any case, they never pursued the indication, despite the fact that there were good studies to support the efficacy and safety of gabapentin. Since then, we have found some controversial addictive potential of gabapentin. I have hardly ever given a lecture where somebody would not say I had a patient who misused gabapentin, but even if I'm not convinced that it does have a bona fide addictive potential, but even if it does, it is certainly much lower than that of benzodiazepines. In practice, we do use gabapentin quite a lot, and one of the ways that we use gabapentin is also for its for the fact that it comes in such big numbers of milligrams, which helps with patients who are attracted to medications. What am I saying here? A patient is given 100 milligrams of gabapentin 3 times a day. 300 milligrams of gabapentin a day is not really a big dose. It's actually a very small dose, but to patients, that's a good thing. That's a good doctor. He gave me 100 milligrams 3 times a day. Now that he can do the job. What do you expect, like the little Risperdal, for like 0.5 or 1 milligram, twice a day? That is no medication. Gabapentin, now we're talking. So we somehow ride the wave of a placebo effect as well with gabapentin, and of course its anxiolytic effects and which are significant. So we do use it in clinical practice, but it's not FDA approved for the treatment of alcohol use disorder. Topiramate, on the other hand, does have some very good data behind it. Bancoli Johnson, as you probably know, has done a lot of work with topiramate, both for alcohol and cocaine. At some point, we really thought there was going to be another medication at par with naltrexone and acamprosate, but the enthusiasm for topiramate as a direct medication for alcohol use disorder has somewhat fizzled over the past few years. We still use it, especially if you have another indication for the medication and you want to to address 2 issues with one agent, then that is certainly something to consider. It does have some very mild mood stabilizing properties, and it does result in some weight gain. A lot of patients are particularly attracted to topiramate because they lose some weight with it. Not necessarily a good reason to just give it the medication just for that. Baclofen, a muscle relaxant, has gotten great popularity, especially in Europe, especially in France. There's a single physician there who is very vocal about his own experience as a surgeon of being a very heavy alcoholic and not responding to 12-step or psychotherapy or any medications or anything, and then put himself on high-dose baclofen, and not only he stopped drinking, but he realized that his cravings for alcohol went down to 0. Invited him to give us grand rounds. He explained he's a very charismatic man, and but still the research on baclofen continues to be small studies, a lot of them open label studies, and it is not, unless you have good reasons to take advantage of the muscle relaxant properties of baclofen, then we don't recommend for the treatment of alcohol use disorder. And then finally, aldosterone, it's misspelled here. It's a medication that may be particularly helpful for patients, for early onset alcoholics, for patients who suffer from, who have got the diagnosis of alcohol use disorder before the age of 25. There's a wonderful study, I believe by Ismini Petrakis, that showed that sertraline may be particularly helpful for older patients who suffer from alcoholism, but not necessarily for younger ones. And aldosterone is the one that may be particularly helpful for the early onset alcoholics. It is not FDA approved, and I'm just bringing it up here for completion purposes rather than anything else. Okay, I think we did it. I think this is it for the medications for alcohol use disorder. I just have one slide on the psychosocial interventions. I want to make absolutely sure that we don't forget the three major parts in probably in today's treatment. Alcoholics Anonymous, a wonderfully powerful and effective intervention for our patients across the globe. Not for everyone. I will be the first one to say that it's not for everyone, but it is good for and extremely effective for a lot of patients who suffer from alcoholism. Cognitive behavioral therapy, most correctly should be cognitive behavioral therapy, but in any case, most of us call it cognitive behavioral therapy, and motivational interviewing, the major psychosocial interventions in 2021. There are other things that are being studied. Mindfulness certainly is edging its way in being a bona fide fourth psychosocial intervention. Physical exercise may very well end up being up there, although the data are not so robust at this point. So stay tuned. All right, a few words about benzodiazepines, as I promised. An effect very similar to alcohol. If you remember the different levels of alcohol BALs that I presented earlier, we have the same kind of progression from relief from anxiety to sedation, general anesthesia, coma, and death with benzodiazepines. They are not benign agents, and most of us talk about the addiction liability of benzodiazepines, and we all know about that. We know about the addiction liability of shorter acting benzodiazepines, very much like alprazolam, but there are other things that go along with benzodiazepines, sedation, cognitive and psychomotor impairment, and perhaps the one that is the most troublesome one of all, that falls in the elderly directly, caused by the use of benzodiazepines. My friend Rick Reese came up with this kind of quick and dirty guideline for people who prescribe benzodiazepines, that if your patient takes half or less of the maximum dose listed in the PDR, then you're in the green zone, meaning that most likely the patient would be okay to use this stable dose of benzodiazepine. If you're in the red zone, you're above the maximum dose listed in the PDR, and this is a frank addiction, most likely a frank addiction, and this is something that needs to be addressed as a substance use disorder. What it's interesting to me is here the yellow light zone, and that is the in-between, and Rick says not many anxious patients live in this zone. And that is probably true. We do see the benzodiazepine taking patients, segregating to the two extremes of this diagram right here. I couldn't possibly finish a lecture that started with the epidemiology of anxiety disorders without saying something about the treatment paradigm shift in the pharmacotherapy of anxiety disorders. When I was a first-year medical student at Stanford, as Dr. Abadi said, then I was taught that for depression, we give antidepressants, and for anxiety, we give anxiolytics, meaning benzodiazepines. And of course, that has completely gone out the window. And in 2021, for some time now, for depression, we give antidepressants, and for anxiety, we also give antidepressants. The way to remember that is that if you think about depression being primarily preoccupation about the past, anxiety being primarily preoccupation about the future, they both seem to have a similar underlying engine. They both involve the serotonin system, and they both seem to be responding to similar agents. And that's, of course, how we treat anxiety in 2021. We occasionally do use benzodiazepines, but certainly not as a first-line treatment for any of the anxiety disorders. All right, let's just spend a minute maybe or so to review the 6 chapters of today's talk. So we started with COVID-19, and it has increased the self-medication of anxiety disorders, but that is primarily true for people who have the severe form of alcohol use, people who suffer from alcohol use disorders. Screening and brief interventions are effective, especially for alcohol, not so effective for harder drugs, but for alcohol, brief intervention is effective and has this three-part structure that I explained before. In terms of withdrawal, we use long-acting benzodiazepines like chlorodiazepine, unless the patient is elderly or has significant problem with their liver, in which case we use lorazepam, a shorter-acting benzodiazepine. Going into the pharmacotherapy of alcohol use disorders, the main part of this lecture, 2 medications should stick as top of the list in your mind: naltrexone and acamprosate. Naltrexone is best for people who want to cut down. Acamprosate is best for preventing the first drink. Naltrexone cuts down the reward cravings for alcohol, the galloping need for more and more and more and more alcohol. Acamprosate interferes with the glutamate system and with the abstinence cravings for alcohol, the need to self-medicate the protracted withdrawal syndrome. In terms of psychosocial interventions, Alcoholics Anonymous, I would put it as the first-line intervention for alcohol use disorder. That's my opinion, but it is supported with a lot of data. And finally, just a word of caution about benzodiazepines, particularly with the issue of falls in the elderly. All right, and with that, I want to thank you very much for your attention. I also would like to thank my colleagues, the people who helped me put together our addiction assessment and treatment book. And these are the people who have been working with us for some time now, and I'm deeply indebted to them. Thank you. Hi, Amir.
Hi. I'm not muted, right? Okay, good. So we have some good questions here. Thank you so much. I have a ton of questions myself, but I'm going to leave it to the audience because maybe we can talk later. Because even though I've learned this topic many times over, I still find, and something I'm sure you know as an addiction psychiatrist, you can't underestimate is how patients can figure out ways to trick you, even with antabuse, even with naltrexone. They seem very knowledgeable. The patients at Silver Hill came to me after the article in The Atlantic about the Sinclair method and naltrexone. And so I'm curious your thoughts about that, about the Sinclair method, and like how you manage when you have patients come in like with articles they've read online about baclofen or about anything, the hottest new trend. And of course, they're insisting on wanting to try it, even though the evidence isn't particularly strong for a lot of these things. So
What a wonderful, wonderful first question. Totally left field. I was expecting more something specific about the medication, but this is just so much more important. And of course, it speaks volumes to me. The latest one, I think, is the Demi Lovato, the California sobriety idea. I don't know how many people have heard that, but she is saying that she would like to continue drinking despite the very severe problems that she had with drinking, and do the California sobriety style, which I think it's a version of moderation management. The Sinclair method goes along with naltrexone. Naltrexone has been studied, I think, more than I don't know any other medication. What's even more impressive with naltrexone is the range of dosing that has been studied, from micro dosing of naltrexone, 1 milligram or less than 1 milligram, to mega doses of naltrexone, several hundreds, which of course can be dangerous for your liver as well. In some ways, tricking the body into not believing that they have a problem with alcohol and being able to continue drinking despite the fact that they have had a tremendous problem with it is the holy grail of our world. And if I can summarize, the field has taken an approach that is not quite as black and white as it was a few years ago, where it said only abstinence would work and nothing else. And now we're much more open to versions of that. The overarching answer, I think, is that the more severe the disorder, the more severe the alcohol use disorder, the less likely the moderation management techniques and Sinclair or anything else would be helpful to the patient, and a more kind of a focus on abstinence would be helpful. I just took the APA exam. The APA was this past weekend, and I had a self-assessment exam. And one of the questions that I got wrong was what should be the goal of treatment for adolescents who have problems with alcohol. And I think I said something that depending on the patient's goals, and the correct answer was abstinence, and only abstinence really would work for somebody who has a severe problem with alcohol in adolescence. All that to just move to the real question that Amir is asking me: what do you say to patients who come up with wonderful books or websites, more likely, or TV shows, and say that I've heard this and this and that? I don't shut them down. I say there are a lot of things I don't know. There are a lot of things that may be helpful. I'm going to look it up if there's something that I haven't really heard that kind of data myself. If I happen to have seen that data, then I'm very straightforward with them. Yes, it may have helped some people, but in general, we find that the cost benefit of this kind of intervention is not particularly favorable. And the main issue there is not to collude with a patient in a treatment that will deprive them from the ones that they're just so well studied and so well documented. Meaning, it's okay to say to the patient, go ahead, have these dietary supplements. There's a good chance that they're not good, these dietary supplements are not going to hurt them. But on the other hand, there is some chance that's going to sway them away from doing the hard work of recovery, of actually following a tried and true protocol that will have a much, much higher chance of success than, let's say, something that they read over on the internet.
That's certainly true. And I think that's important. Dr. O'Brien from Penn gave a talk and said that at Silver Hill, and one of the things he cited was there was a paper where he talked about the small number of patients who actually get prescribed medications with alcohol use disorder. He said, we're not actually prescribing these meds and offering them. Yeah. So the education of psychiatrists, especially those who don't have experience in addiction, is really important. So
let me just put, I mean, here I am giving a talk on the pharmacotherapy of alcoholism, and I certainly would like people to consider them and suggest them to the patients and write for them and so on. But I just want to contrast that, let's say, with buprenorphine for the treatment of opioid use disorder. It's not exactly at the same level of efficacy. As you probably know, there are quite a few studies that have shown that buprenorphine is very effective for the treatment of opioid use disorder, even in the absence of psychosocial supports. Not the same for alcohol. There's not a shred of evidence that the medications for alcohol use disorder would really address the issue in the absence of psychosocial supports. Even the ones that for naltrexone, the injectable naltrexone, they all have a psychosocial component to them. So let's just be careful about that.
Yeah. So thank you for saying that. I have a few questions from actually Dr. Francis, who was former president of Silver Hill, and he has some really good questions. But let me start with the first one being, in the era of motivational interviewing, is there still a role for coercion in some cases? So that's the first question.
Absolutely, there's a role for coercion, and I believe Sheila Bloom, Dr. Bloom, the late Dr. Bloom, I was the first one who described the spectrum of coercion in addiction. I think that Larry Westreich has incorporated in one of his books the spectrum of coercion, and the idea there is that the majority of our patients come to us for treatment because of coercion. On one extreme, it could be the most severe one, a judge who says either you go for treatment or you go to jail. I mean, that is pretty strict coercion, but there are all kinds of shades of coercion in between. The wife who says either you go for treatment or I take the kids and I'm out of here, or the even more subtle ones that have to do with the person's social environment and dating circumstances and so on, that may very well coerce her or him to come for treatment. So we do, not only we accept, we celebrate coercion whenever we can, and motivational interviewing by no means goes against coercion, especially in the maintenance phase of treatment. Motivational interviewing very explicitly says you recruit everything you've got, internal resources, external resources, everything to keep the patient safe. And I think coercion very, very well can be used in that matter.
Yeah, good. I've seen it work, and it used properly. In our hospital, for instance, it could definitely help with that.
It has changed the flavor a little bit when you think about Nancy Petrie's work and contingency management. So instead of coercion at the end of the line having a punishment, we prefer to have a reward at the end of the line, but it is coercion nonetheless.
I want to, before I get to Dr. Francis' other questions, let me just throw in another question that someone asked before I forget. Someone asked about the naltrexone implant, the 6-month implant. I don't know if this is fairly new. I don't know if you have any information about that you could share.
Naltrexone implants have been used quite extensively in Europe. Not quite extensively, that's not correct. Have been used for a long time. Not extensively, but for a long time in Europe with very mixed results. All the way back to the Soviet Union, I believe, but certainly in Russia, now they were used because there's no agonist treatment for opioids. So, naltrexone was the treatment for opioid use disorder as well. And horrific stories of people trying to rip out the naltrexone implants from their arms. I'm not sure how well it will fly here in the United States. People very much, for example, the buprenorphine implants, Probuphine, that was introduced, about 10 years ago, and with great fanfare, going underneath your bicep, and they have not really fared very well. Of course, it could be a dosing issue. There was a little on the lower dose of buprenorphine. but we'll wait and see. We'll see where we go with that.
Right.
In terms of implants, I just have to say, we were at one of the centers where we studied the buprenorphine implants, and when we're recruiting for patients for the implant, I thought to myself, we'll never get enough patients. As soon as we opened the study, the line was like going, around the block at the Addiction Institute for people to come in and try to get into the study. So there are some people who may be attracted to it.
Well, one of the problems I've had is getting people even to agree to get the naltrexone injection.
Yeah.
I was like, I would have a hard enough time getting, patients are so reticent about it because it stays in their system, it's irreversible, even though it's not irreversible. If they're fearful, they have a reaction. So I would have a hard time selling an implant, let alone even an injection.
I think the injection part has a psychodynamic aspect to it. I think it has a meaning for a lot of our patients. It is a punishment of some sort. Certainly patients who have had, haloperidol and lorazepam with diphenhydramine injections in inpatient psychiatric units or emergency rooms certainly believe that an injection is a testament that they're bad people, that they are not really, high enough in status to get the oral medication, and they have to be punished to get the needle, as they often call it. So these kind of things do have psychodynamic meaning for our patients. The combination product of buprenorphine with naloxone has a bitter taste, and patients used to always ask for the mono product, not so much because they wanted to crush the tablets and inject them. It's just because they did not want the bitter taste, which in their minds was punishment for being addicts. There are these considerations as well.
Well, that's true also for antipsychotics. John Kane, I heard him give a talk at LIJ, and he said he thinks that injectables, long-acting depot injections could be used for people early on, not just non-adherent patients, but people view it as a punishment for being bad patients. So
yeah.
I have another interesting question from Dr. Francis about how you feel the increase in marijuana use is affecting alcohol use disorders.
That has been best studied in adolescents, and you all have heard about the gateway theory. What most people feel these days is that the three things, marijuana use, tobacco use, and alcohol, are highly predictive of one another, meaning that it may not be that one leads to the other, but if you do use marijuana in adolescence, then you have very high chance of also using alcohol and smoking cigarettes. If you smoke cigarettes, then you have a considerably higher chance of using alcohol and using marijuana. So there is a triad of problems that seems to be coming hand in hand in adolescence. I'm not sure about the connection in adulthood and how strong it is. It has been also studied in driving under the influence. We do know that the combination of alcohol and marijuana is particularly problematic with driving. Very simply put, marijuana, cannabis impairs the more automatic parts of our driving, but if we don't use alcohol, then a lot of people are able to compensate by being very, very cognizant about their driving and using these higher order processes in our brain to compensate for the loss of automaticity due to cannabis. Enter alcohol, that deprives people of this higher order, more cognitive sharpness, and therefore they have the cannabis that has affected the automatic part of driving. You have alcohol that has affected the higher order, being able to think out your driving with catastrophic consequences.
Then one more follow-up question, that I think you kind of addressed it a little bit, but it's educating psychiatrists about the danger of benzodiazepines and their overuse. I'll just sort of give some context on this because I started off doing research in anxiety disorders with the people at Sinai, and even at the start at Columbia, Jack Gorman, and a lot of anxiety people have a different view of these things. I've read a lot of Richard Ballin at Wayne State. He's seems to be very much protective of the benzos, the old guard. But I'm always curious whether these people ever work with people with addictions, because it's a whole other kind of atmosphere. I went from an environment where they thought benzodiazepines are maybe not the most cutting edge, not first line, but they didn't seem so averse to it. And now it seems like everyone's afraid to prescribe them, and there's such a strong backlash against benzodiazepines, which, by the way, I'm giving a grand rounds next week on this very topic on anxiety disorders. So I'm preparing my slides, but it seems like I have a hard time convincing people that yes, they're good treatments, but they're not really meant to be first line, and that we're looking for more cutting edge novel treatment. So what are your thoughts about educating people? And I guess a follow-up to that is, how do you feel like we can get patients to get on board with psychotherapeutic approaches to treating anxiety when they have alcoholism? Because that seems to be the biggest hurdle to overcome.
Yeah. On the first one, there are two types of psychiatrists. There's one who says, I fully appreciate the use or the usefulness of benzodiazepines in treating patients, but we should always remember their addictive potential, and we should be very worried about that. And the other half of psychiatrists say, I'm fully aware of the addictive potential of benzodiazepines, but we should never forget the usefulness that they have in treating psychiatric disorders. So it's where you put the emphasis in this argument. There's this older study, and I cannot really find the reference from it. Frank Levin was the one who referenced it at some point, who said that they asked psychiatrists whether they prescribe whether they prescribe benzodiazepines or not, and something like 30% of psychiatrists said that they prescribe buprenorphine, and then they contrasted that with pharmacy records, and they found that it was like 80% of the same psychiatrists were actually using benzodiazepines. So in some ways, we're closeted benzodiazepine prescribers, meaning that in actual real life, a lot of psychiatrists do prescribe some benzodiazepines, primarily because of patient pressure. Patient can exert significant pressure, and then you can make an argument in your mind that in order to preserve the rapport with the patient, then maybe I can give them a short course of benzodiazepines and then see where we go with that. In terms of the psychosocial supports and psychotherapies, patients have a good reason why they're reluctant to it. They're expensive, they're time-consuming, they're not covered by insurance quite often. So there are many issues with psychotherapy. Two ideas there. One is the apps. There are more apps now that offer CBT that may be helpful. They're not 100%, and I absolutely do not advertise them, because they have not figured out the interface with the therapist very well. But I think it is the way of the future, and especially CBT or biofeedback, things of that sort will be very amenable to your cell phone, to the apps. Something like the Fitbit for exercise, along those lines. And the second one is that although, of course, we don't consider Alcoholics Anonymous 12-step programs to be treatment, we consider them to be interventions. They do share a lot of characteristics with psychotherapy in terms of the support, in terms of the group, in terms of so many things that I would make absolutely sure that I have exhausted the route of the 12-step program before giving up on the patient, on following up with some kind of psychosocial intervention.
Oh, wonderful. I think that covers everything, and we're out of time. And I want to thank Dr. Levounis for an excellent talk. I really appreciate it. I thought it was an excellent summary of where we are, and I think it's going to be really helpful for the audience who either are treating patients, or sometimes we have patients participating in the grand rounds as well. So thank you. If you want to get credit, just log in to the Q&A, or you'll get an email. But I hope we'll have you back to talk about maybe something, motivational interviewing or something. We'll bring you back at some point.
All right. Thanks so much, Amir.
Thank you.
Bye.